first discussion will be with Dr. Furr and Ms. Matthews. I frequently hear from Iowans about poor access to health care services, especially in rural areas. In many states, pharmacists, audiologists, and more are licensed and trained to perform certain medical services that Medicare doesn't pay for. Example, right now, pharmacists cannot get paid under Medicare Part B rules for providing wellness screenings, immunization, diabetes management. I support modernizing federal rules. Should modernizing federal rules to match licensing and training laws in the various states be a part of strengthening and improving healthcare outcomes for patients with chronic conditions?
Thank you, Senator. And I know you're concerned about rural areas and the importance of the geographic index also, and that we're protected there. Yes, I think so. That, the problem in the rural areas also is everybody's overworked, and my pharmacists are doing everything they can to fill their prescriptions. I don't know how they could even possibly consider doing wellness visits if they had that time to do that. But at this time, I mean, they're trying to do that and do immunization. So we're all overworked, and I don't know how they could actually do that personally.
Thank you for the question, Senator. I would just share that in the advanced alternative payment models that we've made investments, including in the rural communities, to help support pharmacist engagement with the patients and the providers to help support that kind of work. Those are the kinds of things that ACOs do without a billing code, because they're responsible for the total cost of care. So wrapping the services around, the ACOs are making investments to help bring additional access to these communities. That's inherently baked into the models.
Dr. Furr and Dr. Navalthy, I've championed efforts to ensure Iowa physicians and in other rural states as well get paid fairly for health care services. Iowans pay the same amount of money in Medicare as everyone else. The physician's labor market is not local but national, especially with the expansion of telehealth. Throughout the end of this year, Congress has established the Geographic Practice Cost Index, Gypsy, for short, that floor to ensure that rural state physicians receive a fair reimbursement. So to you two, is CMS using the more current and complete input data for Gypsy to determine physicians' payments?
The FP has strongly endorsed that and keeping that floor. The one thing we've learned from COVID is suddenly all of my nurses decided they could be travel nurses and make 2 or 3 times what they could in rural Alabama. So now we're having to compete with New York and California and Georgia and everywhere else. So if they're going to come back and practice with us, they want to get the same rate. So the labor costs do not reflect, I think, what actually is going on. And inflation is the same everywhere. Our costs are just as great in our state as it is anywhere else and in rural Iowa.
No.
Thank you, Senator, for that question. I think it's correct that the way the labor markets are functioning now is different, as Dr. Furr has highlighted. And there are needs to update the data to reflect that. And there is granular data that's collected by other agencies across the U.S. federal government that could be used to update the input data, for example, for the Gypsy, which I agree is so important.
A follow-up for you, Dr. Furr. Currently, 36 states have statewide areas for Gypsy and don't distinguish more urban areas within the rural states. Should there be more geographic areas to account for this?
I certainly think it's important that we have the right geographic designations for us to be able to categorize the way that labor markets work and the way that individuals actually do, so, for example, commute from rural areas into urban areas or vice versa. And so I think, as you're highlighting, re-examining so we're constantly up to date on how the markets function is absolutely correct.
Yeah. To you two, I'm going to shorten up my introductions by just saying, asking this question: is Medicare Advantage an effective model to expand and improve chronic care management services for seniors while also lowering Medicare spending?
So I believe there's two sides to this. I think, on one hand, Medicare Advantage, which is more generously paid. MedPAC, for example, has put out estimates that Medicare Advantage payment is up to 20%, maybe even more than that, more generous than the traditional Medicare program. Those dollars are at least in part being deployed to support things like transportation, which the traditional Medicare program does not have any support for. That I can say from my own personal experience has been critical at times. Very, very, very important to get beneficiaries who have disabilities, for example, to their appointments, because otherwise it can be very hard. On the flip side, because there is such generous overpayment, if you will, to the Medicare Advantage side, it's hard to know whether we're really getting true value from all of those dollars. Certainly there's some value in the supplemental benefits that are helping chronic disease care. But are we really getting value from it? And I would say we don't know the answer to that, and that's a very challenging question for us to wrestle with. One thing is for sure, there is not symmetry across traditional Medicare and Medicare Advantage. It's very hard for us to deliver the same kind of tailored care and traditional Medicare unless we do alternative payment models like ACO, as Ms. Matthews has highlighted.